The next one, let's see, is also a 15-year-old female with a deep soft tissue mass of the leg. And as you can tell, I make up all these histories pretty much. So, all right. So what did you think the diagnosis was for this one?
So I believe this would be the alveolar rhabdomyosarcoma.
Good.
Yeah.
That's what it looks like to me. I probably should check my answer sheet and make sure that I'm not telling people wrong because I haven't looked at these for a long time. But yes, this is alveolar rhabdo. And again, it looks very different, right? I mean,
Right.
it's a round blue cell tumor. It has really prominent fibrovascular septa in between, dividing out these nests of tumor cells. And this is kind of akin to how alveolar soft part sarcoma can have solid areas. You can also have solid areas in alveolar rhabdomyosarcoma because the way they make the alveolar architecture is the same. The nests kind of break apart, right, and become discohesive. And so this can really confuse people again because they're expecting it to look alveolar. And you can see it beginning to get alveolar like in here, right? It's beginning to kind of break down. But if you see a round blue cell tumor, alveolar rhabdo should be in your differential diagnosis in general. If a Desmond is a really important stain to do in the workup of a round blue cell tumor. And I think that can get overlooked sometimes. And here you can see them getting discohesive again. The fibrovascular kind of septa in between the nests is very helpful. The cells are round blue. Some of them will have some eosinophilic cytoplasm and can look kind of rhabdoid. We see a little bit of eosinophilic cytoplasm. Sometimes you see actual rhabdomyoblasts, like what they call like strap cells that are kind of like what you'd see in embryonal rhabdo. You can see those kind of scattered. Maybe like that guy there, they have like a little bit more prominent eosinophilic cytoplasm. Striations you could sometimes see, but you got to really hunt around usually to find striations in rhabdomyosarcomas, I feel like. And then, like you said, those multinucleated wreath cells, let's see if we have any here. Those are quite helpful diagnostically, and they're usually present. But see, I mean, if you just had that, a high power pick of that, I mean, that could be anything, right? That could be a lot of different round blue cell tumors. I can't quite get it. It's a little bit too bright there. That's better. And that could be a wide range. You could think of Ewing's or Ewing-like sarcomas. You could think of a lot of different round blue cell tumors. Yeah, I don't know if I see the wreath-like ones. Well, I had a nice case that I pulled up the other day to use for a different video, and I guess I should have kept that one around. Well, in any case, they're multinucleated tumor cells with pink centers and nuclei around the outside. And if you Google it or look it up in a book, you should be able to find nice pictures. Dr. Weiss's book has good pictures. And I guess it sounds like you've already looked it up because you knew exactly what you're looking for. So these do tend to occur in children, sometimes young adults. I have seen rare examples in older adults, but it is extremely rare. But it can happen. So alveolar rhabdomyosarcoma. And among the rhabdomyosarcomas tends to be more aggressive than embryonal. And so what's the, did you see the, what was the question we had for this one? What's the molecular abnormality here?
So the translation location of 1 and 13 or 2 and 13?
Right, and that involves PAX3 or PAX7, and FOXO1 is the partner gene. Nowadays, I feel like, and I don't see these very often, I feel like they more often go to pediatric pathologists, but I feel like most of the time now people are pretty much always confirm them with molecular. I mean, this looks very characteristic and classic, but because the treatment protocols and the prognosis is different than embryonal rhabdo, I feel like usually people want to have the molecular to sort out for sure between embryonal and alveolar. Usually they look different, but I've seen times where it can be hard to tell them apart. So, all right, now what is the immunostain pattern you would expect in an alveolar rhabdomyosarcoma?
So Desmond and MSA should be diffusely positive, and then myogenin and MyoD1 should have nuclear positivity, and it should be diffuse.
Yeah, that's the key there. Desmond, I don't know. I don't use MSA very often, so I'm not sure, but it wouldn't surprise me to have it positive. Desmond, definitely you want to have positivity, a lot of it usually. And myogenin, should be like strong diffuse nuclear positivity, like 90% or more of the cells. Whereas in embryonal rhabdo and some of the other rhabdos, it can be more patchy staining. This one, this makes a great control. If you get an alveolar rhabdo, it's good control tissue because it's just like all the nuclei, blazing positive for myogenin. And I tend to like myogenin better than MyoD1 just because in the labs I've been in, at least, it has is more clean stain, and MyoD1 can have a lot of background cytoplasmic staining, which is non-specific. So I feel like the labs where I've worked before, we've had trouble getting MyoD1 to work very well. Although it is a good stain, it's just I feel like harder to interpret. So my experience has been mostly with myogenin, or also known as MYF4, MYF4 is the other name for myogenin. It's always good to learn the alternative names, for immunostains, because you never know, on a test, which name will get asked, and it's terrible to know something but not know the alternative name and be like, but I knew that fact.